Welcome to the Grace and Grit podcast, made for women who want their healthiest years to be ahead of them, not behind them. Join your host, Courtney Townley, right now as she breaks down the fairy tale health story you have been chasing all of your life into sensible action steps and lasting change. Hello, my friends, and welcome to the Grace and Grit podcast. This is your host, Courtney Townley. As always, thank you so much for being here. For nearly 3 decades now, I have been helping women, mostly midlife women, take better care of themselves with more consistency and ease. And a big reason I'm so committed to that work is because I firmly believe we have tremendous power to influence our health story and the way that we age. And having worked with so many midlife women over the years, I am very familiar with the challenges and frustrations that arrive as women travel through the menopausal transition. And I am a midlife woman, so I am deep in the throes of my own menopausal transition. And I cannot say this emphatically enough. Menopause has not gotten the attention that it deserves until now. There are people like my guest today, Dr. Mary Claire Haver, who are really making it their message and mission to help women navigate this stage of life with more support than they've ever had before. Dr. Mary Claire Haver is a board-certified OB-GYN. She is a culinary medicine expert, a Menopause Society Certified Practitioner, and the founder of Mary Claire Wellness, a private medical practice that specifically focuses on women in midlife. If you have never heard of her name before, Dr. Haver has taken the internet by storm with her advice for women on how to navigate the path through hormonal change with power, purpose, and facts. Information that is so long overdue. So if you're a woman or you know a woman, Dr. Haver's newest book, The New Menopause, is an absolute must-read because it provides so much value in better understanding what is really going on in the menopausal transition and how we can best support it. Because while menopause is inevitable, suffering through it is not. So in this interview today, we cover a tremendous amount of ground. But some of the things that Dr. Haver generously shares are things like why she was so compelled to write this book, how to advocate for the care that you need, the different stages of the menopausal transition, the cost of hormonal decline and how we can better support it, the truth about HRT, and so much more. So have a listen, take it in, and if this lands for you, if you get some value from this episode, please share it far and wide so women can get the help that they need to make their second half the best half. All right, we have so much to talk about, so let's get into it. Dr. Haver, welcome to the Grace and Grit podcast.
Thanks for having me.
Thanks for being here. And I really do want to start with you, especially in this interview, with where I end a lot of my interviews, which is with a heartfelt thank you. Because the movement that you have ignited around menopausal healthcare is long overdue and so desperately needed. And when I read your book, your new book, The New Menopause, I got really emotional because I saw my mom in the book. I saw my grandma in the book. I saw myself in the book, and I saw every client I've ever worked with in your book. And, when I polled my audience prior to this interview, I told them, throw out questions you want me to ask. And I have to tell you, a large majority of what I got back was just make sure you tell her thank you. Like that was the main message. And that's just such a testament to the work that you're doing and the importance of what you're doing. And I also just want to speak to the way that you wrote the book. You normalize rumbles in such a grace-filled way, and you educate on solutions in such an understandable way. And you really do such a beautiful job of giving women what I think they are so looking for, which is hope that their best years truly can be ahead of them and not behind them with the right resources. And this book is so ripe with amazing resources. So thank you from the bottom of my
You're
heart
welcome.
and from all of my listeners for being here.
Well, I wrote the book for my daughters and for my grandmother. And my grandmother spent the last 10-ish years of her life frail and demented and needing long-term care and just not a happy, functional human being. My mother's on that path. And I want better for my daughters. And so this book is trying to give a framework where we can limit the time that these things can happen.
It is. It's such a relief to read it. And, I would like to, I think, ignite this conversation too with maybe you sharing with listeners as a certified OBGYN, which you are, there's so many things you could have done a deep dive into and that you could have pursued as a mission or a message. Why this? Like, why this topic?
I saw that there was a huge gap in my knowledge and training, and that, to put it in perspective, this isn't a niche. It's so funny when people are like, what's your niche? What's your niche? So I'm like, every single woman over the age of 35. Like, why is it? It was my frustration with, what I learned in my training programs and CME is great. There's just a total gap in the gender health gap, how females are treated medically in research studies, and then specifically around our sex hormones. And it is leading to us having longer lives of dysfunction, and I'm like, I'm just one voice, but I'm kind of loud. And who knew my superpower would be to make interesting TikTok videos about menopause? But, there's a bigger picture here of women who can lead a healthier, longer life if they know these things.
Yeah. I heard an interview you did recently with Marie Forleo, and it was fabulous.
Love
and
her.
You said in that interview that your friend had asked you the question, what if you had been among the 15% yourself? The person who personally had not really experienced the perimenopausal symptoms or menopausal symptoms, that really would have shifted probably the drive to have this conversation. Will you speak to that a little bit?
Yeah. So, part of what fueled and motivated me was my banging my own head against the wall with my menopause symptoms. And I was the girl who brought up in the traditional Western, healthcare, that menopause was a natural part of life. Yes. Okay. Can't deny that. But that, if I just ate right and worked out, I should have an easy time of it. And, I equated my thinness with good health, which is a whole nother discussion, which was not true. And I had a horrible menopause, horrible. And I gaslit myself for months trying to say, oh, it can't be this, it can't be that, not realizing that all the symptoms I were having were due to my estrogen deprivation and testosterone. So, but what if I was one of the lucky 10%, 15% who just kind of skated through and stopped having periods and didn't have any like cliche symptoms? I don't know if I would have been a passionate about this journey. So as hard as the wall was hit for me, it was probably a good thing because I was so motivated to help myself and therefore helping millions of other women.
Yeah. Well, I hate to say that I'm glad you weren't a part of that 15% because obviously you could have avoided some unnecessary struggle. But if it birthed this, so grateful for it. So early in the book, you say that if a woman in perimenopause is not getting top-notch care, it's a matter of life and death, really. And then you go on to share all these incredible stories. Like the beginning of every chapter of your book is a testimony of someone you've worked with talking about how she was either misdiagnosed or ignored or gaslit by the medical industry, and how difficult it was for her to get good information to treat her symptoms and move into postmenopause with success.
So I did that on purpose because I wanted, we picked various stories I wanted women to see themselves in the book,
Mhm.
and or their sisters or whomever. I wanted them to have a connection with a real person and realize that they're not alone, because what was happening was women were suffering in silence and confusion, and then being gaslit and dismissed, and just feeling
Yeah.
so alone, which I think was compounding the severity of their symptoms, right? It was so
Yeah.
awful to feel so isolated and so alone and not understand what was happening to their bodies. So that's kind of the first
Absolutely.
part. You had a second part of the question.
Well, I was going to lead into with that, just why is that happening in terms of there being
Yeah.
such a challenge with women having to go to
Hmm.
medical providers so many times
Yeah.
or feel like they're just not getting the help that they need. Because you speak very beautifully in the book to the gap in the education.
So it's a lack of training. It's this perfect storm of how we treat the aging woman, how we value her, the history of medicine, and how we've taken care of females throughout time. Um, in our healthcare education system with clinicians, how many hours? So in medical school, I had maybe, and so I trained 30 years ago. I went to school a very long time ago, but maybe 1 hour of menopause in all of medical school. And then in my OB/GYN residency, maybe 6 hours. And then until 2018, I was an OB/GYN residency program director in charge of the curriculum. So I know exactly. And we get the papers from the American Board of OB/GYN, and you must teach your learners this. And there was
Yeah.
just the briefest, most clinically insignificant section on menopause. It just got shoved in the box with everything else taking priority. And most of our training was around reproduction. And so, part of it is also, why does all of women's health, which is more than her breast and uterus, by the way, get dumped in the lap of the poor, busy gynecologist? Like, you have enough to do
Right.
delivering babies and surgeries and pap smear and keeping the reproductive system healthy. But, like, what about my brain, my bones, my genital urinary system, my skin, my hair, my teeth, my eyes? How that's all being affected by this? In a perfect world, this would be a normal part of training for 100% of medical students, of learners, of clinicians, of any clinician who touches a female. But
Yeah.
that's not happening.
It's not happening.
I can't tell you how many times, go see your gynecologist, go see your gynecologist, go see your gynecologist. We've segmented this so poorly, and so women are suffering because of it. So right now,
Yeah.
statistically, they did a study in 2023. Woman goes into her healthcare provider, clinician's office, saying, "Okay, I've cliche symptoms of menopause. There's no denying. I have no periods and I have hot flushes." Boom. Only 10% right now will be offered treatment. 10%. And if she is offered
Ugh.
treatment of any kind, 4 to 1, it's an antidepressant. 4 to 1.
Yeah.
And she says, "I'm
Yeah.
not depressed." And they're like, "There's nothing I can do for you." That's a problem.
It's a huge problem. And so can you speak a little bit to maybe the bright side of what's maybe happening now to
Yeah.
remedy that? Like, I do realize it's a much bigger issue than just the gap in education. It's a gap in funding. It's a gap in
Mhm.
research, right? There's all of these
All of it.
places where women have been really misserved.
Sidelined. Yeah.
Absolutely. And so what is happening to sort of remedy that right now?
So so there are political organizations around menopause, not political, but like the menopause mandate. And, there's these organizations being developed to promote menopause care that are helping to push legislation so that we have mandatory dollars being spent on women's health, on the gender health gap, on menopause care. So that's happening. The second push is putting pressure on the American College of OB/GYN, American Board of OB/GYN, to mandate menopause CME as a very, robust part of CME training, for those of us who are out and have to get recertified every year, and then for in the training program. So we're working on that, and then of course, where the really groundswell is going to happen is women educating themselves and demanding the conversation. And so that's what the new menopause is about.
Yeah. And you do such an incredible job on social media. So if you don't follow Dr. Haver on social media channels, she's a wealth of knowledge there. And then is it true that like through the questions you were being asked and just the frustration you were sensing among the people you were interacting with on social media, that you felt the need for this book in terms of women were
Mhm.
lacking this very information?
Right. So I'm like making videos, 6, 7 times a day, posting continuously. And then people would be like, wait, where was that video on frozen shoulder? And, most
Yeah.
of what I've learned about menopause outside of hot flashes was informed by you, by my followers, by people who saw, listen, and ask the questions. And then, when 10,000 people ask you in your DMs, and I'm not exaggerating, about frozen shoulder and menopause, you start looking, and I don't automatically dismiss. I get curious. I go dig, and then I find, and then I share on social media. So I just needed a place to put all that together that I was learning.
Yeah.
And then I met the Menopause and started interacting with other people like me. This don't have yet. They're getting there as big of a following. And like, finally, I'm not screaming into the void. Finally, I'm seeing people like-minded who are like, this is a ridiculous and we got to change this. And so that kind of just bubbled up into, let me write this book so I can get it all in one place.
Yeah. You're not just lifting the women needing this knowledge, but you're also lifting other professionals who can speak to this and help to spread that message. And that's what you mean by the menopause. Yes. Will you clarify that for people who don't know what it is?
So it was a joke. It is a group of really a more multi-specialty. So it's urologists, cardiologists, of course, OB-GYN, nurse practitioners, family medicine doctors, aging specialists. We have, endocrinologists, of course. We have oncologists who have just banded. It's a group chat, and so we wrote the rebuttal together for the Lancet article that kind of came out, on a national, on an international stage, and basically said menopause isn't a big deal. Go get some therapy, you'll be fine. And we were like, oh, hell no. And so we wrote the rebuttal. So through that friendship of writing a paper together and, respecting each other's thoughts and opinions, we've just bonded. And we're now just kind of this little group where we're always sending medical articles back and forth and really supporting each other's work and practices.
And then we get to benefit from all that.
Yeah.
Which is fabulous. So let's talk a little bit about why women seek out help, because we're talking about a large span of years between perimenopause and postmenopause.
Mm-hmm.
And
Mm-hmm.
a lot of menopausal symptoms are sort of turned into a cliche, right? Of just hot flashes or mood swings or being difficult to deal with.
Right.
And there is so much happening, because I think you expressed so beautifully that estrogen literally affects literally everything in the human body. There's receptors everywhere. So can you speak
Mm-hmm.
to some of the things that women are seeking out help for, or they might be experiencing and they're looking for solutions to?
Right. And they may not realize it could be related to their menopause. Yeah. And so if we like break it down head to toe and go, or, in general, organ system by organ system, let's start with the brain. So the top. So our brain, we have mental health changes. So we see a 4-fold increase in new diagnosis of mental health disorders, specifically depression, anxiety. And we also see brain fog. So we see cognitive deficits beginning to start. The brain, the chaos of perimenopause. So pre-menopause, we have a very EKG-like predictable rise and fall of our hormones in a healthy woman, like outside of PCOS, that will, like on day 14, this is going to happen. On day 28, this is going to happen. It does ebb and flow throughout the month, but the next month, it's going to look very much the same, barring pregnancy or nutrition stuff. So the brain likes that. The brain likes uniformity. The hypothalamus is constantly sampling for estrogen in our blood. And when it gets low, it sends a signal to the pituitary saying, talk to the ovary, tell him, let's get this going this month. Let's get that estrogen back up. Through the process of ovulation, we increase our estrogen. So, and that goes month after month after month until we reach a critical threshold of our egg supply. So remember, females are born with all of their eggs. Men make theirs fresh every day. Okay. They make their germ cell. It's called germ cells fresh every day. In their testicles. Okay. So kick men out of the equation. We are stuck with the amount we're born with, 1 to 2 million. By the time we're 30, we're down to 10%. By the time we're 40, we're down to 3%. This is why fertility decreases with age in a female. Okay. Sure. So when we run out of eggs, that is menopause. So in peri, we reach some kind of a critical threshold, and it's different for each of us, where those signals coming from the brain don't work as well because the quality of the eggs is down and the number is down. So we become resistant to those signals, and the hypothalamus gets pissed off, and it says, I told you to, where is my estrogen? I've been waiting. And the pituitary is like, I sent the signal, and the hypothalamus says, send more. So then the pituitary gets kicked back into gear and sends more and more and more stimulating hormone to get that poor little egg out that month. So that's a delay. We see delays. So cycles become disrupted as far as timing. And then the estrogen levels tend to surge because there's so much FSH and LH there. So we have much higher estrogen levels, and then they plummet to much lower than they ever were in our premenopausal years. Then progesterone never quite gets to where it used to be. So we end up with these anovulatory cycles, meaning we don't ovulate as regularly. And this goes on and on and on in this very much chaotic zone. The brain hates that. Okay. Not only are our neurotransmitters, the signals that jump from brain cell to brain cell that control depression, anxiety, thought process, all the things, those are affected by the levels of hormone levels. And also the synapses are like fried because the hormone levels are changing so rapidly. Okay. And so not consistently. And that's leading to all these brain changes. Okay. It's very real. It's not normal. It's not, it is natural, but you do not have to suffer. Right? So, and it can lead to tremendous changes in a way a woman's brain functions. It's completely rewired through this process. So, secondly, let's go down to the heart, palpitations. Actually, and now I recognize vasomotor symptom like hot flashes or palpitations. Women are going to the ER thinking they're having a panic attack or a heart attack. Heart is pounding out. Nothing will stop it. She's sweating. She's anxious. She can't figure out what's going on. And no one in the ER is trained to say, they rule out the bad stuff, right? Which is what their job is, but they never say, this might be your menopause. What they say is, there's nothing wrong with you. Bye-bye. Take an antidepressant or an anti-anxiety medication. So another thing, if we go to the lungs, asthma, new onset asthma, it's atypical asthma or worsening asthma. Estrogen is a powerful anti-inflammatory hormone. Our gut microbiome completely changes through the menopause transition. More bloating, more visceral fat deposition, decreasing our liver. Oh my gosh, how we process lipids. Triglycerides can go up. LDL cholesterol usually goes up with no changes in diet and exercise, just based on the menopause transition. How we manufacture or how we process blood sugar, insulin resistance increases. So all of a sudden, you're just chipping along, eating what you eat, doing what you do, nothing's changed, and your A1C jumps or your HOMA-IR score for insulin resistance jumps. And so you're like, wait a minute, what? And they're like, oh, it's just a part of aging. Yes. But it's accelerated dramatically in menopause. Men get to age like this. We age like this. So when we lose our sex hormones, and so musculoskeletal, 80% of us will suffer from the musculoskeletal syndrome of menopause, arthritis, arthralgias, frozen shoulder, capsulitis. It goes on and on and on. Women who are on HRT have much lower incidences of these diseases. Women on HRT have lower insulin resistance. Women on HRT have lower visceral fat deposition. So this is the data that women need to know, not just estrogen causes breast cancer.
Right. And so can we speak to that for a second? Because this estrogen causes breast cancer is a very real concern for a lot of people. The Women's Health Initiative, you do a beautiful job speaking to that in the book. Can you summarize it? I know it's a meaty topic, but can you summarize it here just so people understand where that idea came from?
So the Women's Health Initiative was an amazing study. It was the first time aging women were significantly studied in the history of medicine. Okay, it was $1 billion study in the 90s. That's a huge amount of money. We were so excited. And basically, we knew from observational evidence that women on HRT, and the number one HRT at the time was Premarin and Provera. Okay, so not unusual they studied that medication. Had lower incidence of cardiovascular disease and lower all-cause mortality. So the study was designed to say, well, is that an artifact? Because women on HRT tend to be healthier and wealthier, therefore they're not going to have as much heart disease, or is this really the medication? So to prove these things, we do randomized control studies, right? We do 2 age match, we match socioeconomic, 2 groups of women, half are on placebo, half are on the drug being studied. There were 2 groups because women with hysterectomy did not need the progesterone. They did estrogen only. Okay, so off we go. We're so excited. Because we're studying heart disease outcome, we average the age at 63. So we're starting with a much older population than a woman starting HRT typically. Okay. Also, they excluded women with hot flashes, because they were worried that they would know if they had the medicine or not versus placebo because their hot flashes would stop. So they excluded 85% of women with hot flashes. So there's only the 15% who didn't have many symptoms. Okay. That's a problem. All right. And you start much older. So they start measuring. They don't see any difference in heart disease. So, okay. Again, this is much older. They saw in the estrogen and progesterone only arm a very slight increased risk of breast cancer, extremely slight. And it was none in the first 5 years, none if you only did 5 years of therapy. You know, there's many nuances to it. And in the estrogen only arm, they saw improvement in the risk of breast cancer versus placebo.
Yeah.
Okay. So they stopped the study. They call a press conference. So it's not the data set. We've got great information coming from the data set. It's how you interpret it and manipulate the data. They called a press conference at the Watergate Hotel in DC before anyone got a chance to read the study. They hadn't even released it, and said estrogen causes breast cancer. It was the number one medical news story in 2002. It changed the history and the course of women's health for a generation. It scared the crap out of people, even though that data has been walked back. Estrogen is protective for breast cancer. There seems to be a slight, very small issue with the progestin, and it really depends on the dose, the formulation, and the type when other studies have been done in other countries. That's not newsmaking. Estrogen causes breast cancer is newsmaking. 80% of women, 40% of women, 30 to 40% of women were on HRT at the time of the study, okay, and doing great. And then 80% of those threw their stuff in the trash. I never touched it again. So what's the aftermath of that when I talk about that? Yes, they're now suffering hot flashes, night sweats. Now they're going on antidepressants, sleep medications, beta blockers for their palpitations, yada, yada, yada. Okay. They're also ending up in nursing homes at a much higher rate. They're also ending up frail and demented. Okay. Yeah. And this is stuff that this is preventative. And so my goal with the book is not just to stop the hot flashes. Yes, of course, that's important. But it is to decrease these long-term risks of living without our hormones.
Yeah, I've heard you speak to, in fact, I think this morning I saw a post that you made about women are living longer than men, and yet our health is not as robust as men.
So we spend 20 to 25% of our whole lifespan in worse health than our male match counterpart. They live and get sick real fast and die. Boom. Right? Now, this is not all men, and I don't want to offend anyone who's taken care of their father for a long time. But in general, men live a healthier life, more productive life, an independent life, and then have a shorter course of needing long-term care and then die quickly, where women have a much more protracted, poor quality of life before death. And that is what we're trying to avoid.
And it's only been like within the last 100 years that women have really lived long enough, right, to
really experience menopause. Yeah. On average. Yeah.
On average.
Yeah. The average life expectancy did not go much past that natural age of menopause, until the industrialization era. So yeah, about 100 years.
So let's talk a little bit about testing, because it is, and your book really illustrates this in so many different ways, how nuanced the diagnosis is and also the route that someone takes to treat it. But what are women's options for testing in terms of knowing where they are hormonally? This is part of the trick, right? Part of the challenge.
There is no good blood, urine, or saliva test to tell you if you're perimenopausal, not consistently. Okay. Yeah. So I would not waste money on tests that promise that there's no clinically relevant data to suggest that these things are helpful at this point. I would love one. I think one is coming. It's just with those crazy wild fluctuations, these 1-time, 2-time, 3-time tests are not really going to be diagnostic. We're great at postmenopause. I could do a blood test and tell you if you're postmenopausal in 2 minutes. Okay. But perimenopause, no. We make the diagnosis of perimenopause by listening to the patient. Yeah. Believing what she says is true and real and happening to her, not automatically dismissing her as being stressed out or needing some water or more sleep. And then ruling out overlapping things like hypothyroidism or autoimmune disease, inflammatory disorders, nutritional deficiencies, et cetera. Not a great use of money to do a lot of hormone testing in perimenopause. Save your money.
Okay. Good to know. So the hormone replacement therapy, which you call menopausal hormone therapy, correct? Like that's the term that you like to use? Yeah. Can you describe what it is? I mean, I just because for listeners who may not know, like they've never even heard of that as an option, they don't know how it affects their system.
Mm-hmm.
What are hormones? What is hormone therapy? And what are maybe the sources of it that are available to us to help us get through this period with more ease and grace?
So I'll try to keep it simple because the book goes way, way deep into this, and it's
Please.
complicated. But we have, so when most of us say hormones, remember we have dozens of hormones in our body. Vitamin D is a hormone. You know, we have insulin and we have glucagon and we have all these hormones. Hormones nothing but a chemical messenger that goes from one gland to an organ. Okay. Our sex hormones are generally when we're talking about menopause, what are the hormones produced by our ovaries? Estrogens, progestogens, and androgens, which includes testosterone. Okay, so those are the three main kind of types. In the estrogen family, the main biologically active estrogen in our bodies premenopausal is estradiol. Okay, when we talk about body identical, just think estradiol. That is what our ovaries make.
Okay.
Now, naturally, we also make something called estrone, which is created in our fat cells typically from the peripheral conversion in very low levels. It will never, never, never be as biologically active, or unless I've never seen it, be a clinically significant level, and but then it becomes the main hormone in our body, even at its low levels when we're menopausal because our ovaries died. They don't work anymore. So we can't make estradiol. We don't make much clinically significant estradiol. And then estriol is what's made in the placenta when we're pregnant, for those of us who ever have a pregnancy. Now, some of the naturalists, I don't know, I don't want to demonize anything, but some physicians and clinicians are prescribing estrone and estriol as in the forms of Biest and Triest, but we don't have any clinical data for efficacy or safety. So most of us in the menopause who use evidence will use estradiol as our main estrogen when we're trying to replace it. Okay. Because I just want to give you back the water you were drinking. Right now, the best thing I ever could have done was take out an ovary at 25 and reimplant it at 50 and just let that sucker, last till you die. But we're not doing that. That's not a thing.
We're not there yet.
That's the perfection. HRT is a very poor stepchild for that. It's better than nothing. So progestogens, that's going to be progesterone, is our main progesterone produced by the ovaries. And so we usually give that back in the form of oral micronized progesterone. Progesterone in its natural form is a humongous molecule and it doesn't go through the skin very well. So if you still have a uterus and you are getting a progesterone cream compounded, it probably is not protecting the lining of your uterus adequately. And I would ask your physician to switch you to the oral micronized progesterone. And so that just shows a lack of education and knowledge on the side of the clinician who's trying to do their best, but doesn't really understand how all that works. And then we have our androgens, mostly testosterone. And so when I'm giving my patients testosterone, I'm giving her the biologically similar testosterone. I'm not giving her any synthetic options. I'm trying to go with as much, as close to what her body was used to getting.
When it comes to the estradiol, which is, would you say that's the most commonly prescribed? Like that's what you're prescribing the most?
Mm-hmm.
The forms of it, I know a lot of people get confused about because there's oral, there's patches, there's transdermal. Can you speak a little bit to those?
Yeah. So we have oral and non-oral. Okay. Oral is pills, take a pill, right? Non-oral is everything else. Patch, gel, cream, ring, troche, pellet, injection.
Okay.
Those are the main ways to get it in your body. And maybe God's going to make something else new, but whatever. Some have estradiol, some have synthetic forms. It just depends. The FDA approved options, which are going to be covered by insurance, are the patch, which is my favorite way to prescribe it because it's transdermal and it's a steady state. Okay. The vaginal ring, which I love, again, steady state, but very expensive. And most of my patients, it's cost prohibitive. I even choose not to use it because I'd rather spend my money. I can get a patch for $20 and it works great. So, and then the compounded option, creams, troches. There's a spray. Sorry, I forgot the spray. And the gels are FDA approved as well. And so, again, it's personal preference, what your body reacts to. Some people with the patches have a reaction to the glue. They'll have an allergic type reaction. So I'm glad we have options. But, typically I start with the patch for my patients.
And can we talk about who hormone replacement therapy is for and maybe who it's not for?
Anyone who wants it.
The message is so clear in your book that it is for a large group of women. And then of course there are always outliers, people that can't
Yeah.
take hormone replacement therapy.
So if you have a tumor that is harmful to you, that is being fed by estrogen or progesterone or testosterone, this is not for you. Okay, you need to get that treated. And then once you're done with your course of treatment, it is an option possibly. And it really depends on age, stage, etc. Okay, it's a nuanced conversation. Okay. If you have horrible liver disease, severe liver disease, that is where we metabolize estrogen in our body. Not for you. Okay. You're not, it's going to be a very nuanced conversation, possibly having to go extremely low dose because you're going to run higher levels. It's a very, very difficult conversation. Okay. If you're being treated or had a recent stroke or a blood clot, that's a new, again, we need to get that managed and taken care of before we begin therapy. And if you just don't want it, that's fine. I respect your decision, but I hope that decision is made on facts and not fear. And on true information. And that if that's what you choose for your body, it's your body, your choice. I 100% respect that.
Yeah. And how would a woman, because I do know of women who have gone on HRT and not felt their best. They didn't get sort of the magical maybe recovery that a lot of other women were experiencing. And maybe that's because they weren't being properly treated, right? That could definitely be a possibility. But how would you know if it wasn't working for you? Like, what are some of those signs? Like, or that maybe it's the wrong dose?
So, we usually do it based on symptoms, right? So you were feeling X, Y, and Z, or having X, Y, and Z in your blood work. Like I'll often track cholesterol levels, to see how we're doing. And you're not feeling better. You're not sleeping still. You're whatever. I tell my patients it's trial and error. We have tons of options. Yeah. And so are you not absorbing? We need to check levels. Are you, is this not the right formulation for you? Are we too high on this, too low on that? I mean, it is a balance, a dance. And what works for you at 40 may not work at 50. And so, it's a constant touching base with your patient. How's she feeling? What's going on? To make sure that she's being managed properly. Are we missing something else that we assumed was menopause?
Right.
Is there also a thyroid order? Does she also have hypothyroidism? Does she also have an autoimmune disease? So is there something overlapping?
Yeah, absolutely. Can we talk a little bit about, because yes, the HRT, which I think so many women are learning so much through you. And for me, I know it's because I was told by my provider that I wasn't a candidate because I do have a blood clotting disorder. And following you and reading so much of the research, it's so clear that with the right form, I am a candidate and I have to go into it cautiously, but I can still use it. And that is so refreshing to me because it was one of the first things I panicked about when I was diagnosed in my 30s. What am I going to do when I hit menopause? So that was definitely...
My niece had a massive PE last week and out of state. She had just moved for grad school and I flew up there and she, immediately I was thinking the same things for her. Like, how are we going to manage her bleeding? Because she'll be on blood thinners for months, her vaginal bleeding. How are we going to manage her menopause when the time comes up? Is doing the same thing.
Yeah.
So these are real things, and this is precision medicine. So this is not cookie cutter. These are intense conversations. Yeah.
On that note, because it is precision medicine and it's also, right, there's a lot of intel, like information that needs to be taken in and considered to properly treat a woman. So again, it comes back to the provider and finding providers who can help support women through this. So what are our avenues for that? Because this is a source of massive frustration for a lot of my clients is they don't know where to go and they don't know what to ask.
So we're not right now. You have about a 10% chance of being able to walk into your PCP or OB-GYN office and have an informed conversation about menopause. So that's a problem. Okay. So where do you find the 10%? Ask your friends. Have they had a good menopause experience? Did they have an informed, pros and cons conversation with their healthcare provider? That's probably the best thing. Go to that person. Okay. Number 2, go to the Menopause Society, menopause.org, and look for a certified provider. This is not just any provider. They must be certified. That means they took the test. They took the time to study and pass this very difficult test to show that they had basic knowledge on menopause care, okay, and safety. So 3, on my website at The Pause Life, we have testimonials from our providers. I mean, from my followers, and they wrote testimonials, and we just organize them by state and city. So that's
Nice.
another thing. See if something resonates with you, or if there's someone in your area. Number 4 is I'm going to start a training program for clinicians soon, but that's not out yet. Hopefully we'll have that out this fall,
sure.
so that I can help fix the problem, use everything I've learned to teach other clinicians. They're like, I want to do this too. And so I'm working on that. And then there's some great telemedicine providers. There are companies that have been designed 100% to take care of menopausal patients. They saw the gap. They saw the need. These were actually female founded companies that had struggled with their own menopause and said, we got to do this better. And it's just so impressive to me that they did this. So they don't pay me to say this, by the way, and they're all in the book. And I have them. If you go to my Instagram or TikTok, to my link in bio, I have a menopause empowerment guide, 100% free, 14 pages of how to find a doctor, what to ask, what blood work, etc.
Beautiful. Perfect. And I also want to note that in the book, you actually provide resources for how to advocate for yourself in your doctor's office, questions to ask, forms you can fill out to help relay your symptoms to your provider, things of that nature, which I think is immensely helpful. What would you say to the population that says that hormone replacement therapy or menopause in general is over medicalized? Like it's an over prescribed, over hyped up. It's it's not as big of an issue as we're making it out to be. Yeah. What do we say to them?
Okay. So presbyopia, which is why I wear glasses, is a natural part of aging, and no one gives you shit for wearing glasses, right? I can't see without them. I function better with them. I wouldn't be able to be a functional human being and work without my glasses. What about erectile dysfunction is a completely natural part of life? Are we over medicalizing the treatment of erectile dysfunction with these 17 different medication options available to treat male impotence? I'm like, so here's what's happening. So so say only 6% of women in the US right now who are eligible are receiving menopause hormone therapy. Tell me how that's over medicalized.
That
Second of all,
blows my mind. 6%.
She is on a blood pressure medicine, a cholesterol medicine, a sleeping medicine, a anxiety medicine, a depression medicine, 5, 6, 7, 8. We're doing polypharmacy instead of treating the root cause. When you hear the word over medicalized, you remember that is the old menopause. That is a very small subset of some very powerful people who have a vested interest in keeping you small and not functional. And the new menopause is about you living your best life on your own terms with all of the tools available to you. And taking those tools away is a crime.
Absolutely. Wow, I love you. So good. All right. Can we talk a little bit about lifestyle in terms of things that we know help to promote a woman traveling through this phase of life with a little bit more grace and ease? Not to say that she wouldn't need supplemental support or pharmaceuticals.
Right.
But what are the main points that you love to stress to women on this front?
Get enough protein. You're right. You're probably not eating enough protein to support your muscles staying strong as you age. Do the heavy lifting. I grew up in the 80s.
Yes.
I'm 56 next month, or I'm doing the math very soon. And I grew up doing cardio. I just did cardio. I was a cardio queen. I ran, I did aerobics. In the early 2000s, I was doing Beachbody and the 2010s, and starting to do some stuff with a little bit of weights here and there, but it was all about being thin. Trust me. Okay. And then I start realizing, oh my God, I'm so high risk for osteopenia. What the hell? And that the musculoskeletal unit works together. And I don't want to be like my grandmother and frail and can't lift or take care of herself and is bound to a bed. No, so I am, more protein, more heavy lifting, less cardio. And really focusing on nutrition. I just good nutrition was like porn, when you see it. And so, no, educate yourself, get off the internet of TikTok to learn about nutrition. Go and pick up a nutrition textbook. Really learn, because we didn't learn it in med school. And I just was like, well, don't eat hamburgers or whatever, And also that
Mhm.
recognizing that obesity is a disease, a chronic disease, and rather than a fault, a personal failing of someone, you know? And
Absolutely.
so it's multifactorial, and menopause adds another level of complexity to that. And so women who are kind of maintaining
Exactly.
all of a sudden cross the threshold to obesity through menopause, and this is real and this is happening and this is not your fault. And so,
Yeah.
getting the GLP-1s, if that's what's going to get you healthy. I don't think they're for everyone. I think they're being used in med spas too much without proper guidance. But I do think they're a
Yeah.
really powerful tool if that's something that you've done everything you can and it's not working.
Yeah. And with the right, like alongside of that.
Absolutely. I mean, taking HRT or GLP-1 on its own is not a miracle. Okay. If you want
Exactly.
to live a
Yep.
long and healthy life, you must eat the right things. You must move your body in the
Sure.
right ways. You might
Yeah.
consider supplementation. You must lower your stress levels. You must prioritize yourself, your health, and put up boundaries, or you are
Yes.
not going to do well as you age.
Yes. I love that you mentioned that, the stress management piece, because all of it's stress, right? Like that stress bucket, it can get full in so many possible ways. And so taking ownership of how that bucket is getting filled up, I think is so powerful. So you mentioned supplementation, and I just want to briefly touch on it because I know this is a question that I get a lot from clients. What are the things that you recommend a woman over 40 take? Like, are there
Right.
non-negotiables in terms of supplementation, things that you just say every woman should be on?
I wish that everyone could get what they needed nutritionally through food. That would be perfection.
Sure.
That's how we were designed, right?
Absolutely.
But it is so hard to do it. So a
Yeah.
non-negotiable, I think, is vitamin D. 80% of menopausal women, are vitamin D, not just low, I mean deficient. And so,
Mhm.
when a woman comes in, especially in peri, and she has this laundry list of complaints, I'm immediately checking a vitamin D level because it's just active in so many body processes that we have,
Yeah.
and getting her back up to a healthy level, which in my clinic is over 60. And
Okay.
so, vitamin D, I think is huge. It's hard for us to get enough in our diet unless you're eating salmon all day, and
Yeah.
we are not able to get enough through sun exposure. And if we are, we're damaging our skin. You're robbing Peter to pay
Mhm.
Paul. Women by and large are not getting enough protein in their diet. Again, and sometimes I'm recommending supplements while they adjust their nutrition. It's hard to go from eating the standard Western diet to eating an anti-inflammatory diet that's protein forward
Absolutely.
overnight. It is a
Yeah.
transition. So supplements are really helpful there to up your protein intake, but not use it as just as a crutch until you can manage changing your dietary habits over time, right? Because you're much more
Yeah.
likely to be successful if you do it slowly and then consistently. And so fiber,
Yeah.
women are only getting maybe 10 grams of fiber per day. We need 25 minimum, probably 30. And so using a fiber supplement, I mean, gosh, there was a great study that came out of, I think, the British Medical Journal, looking at cognition scores and fiber intake. And it was dietary fiber plus supplements, and in men
Yeah.
and women, and they showed much higher cognition scores in people who ate higher fiber. I mean, these are the things that people need to know. And so if I just tell my patients, get a nutrition tracker, eat healthy for 2 weeks, come back and let's look at it. And so we're looking at how
Yeah.
much magnesium was she getting, how much calcium in her diet, how much, fiber, how much, omega-3 fatty acids. And then we're like, okay, what would be some easy hacks for you to get these back in your diet? Let's make those changes. Now, when we're still struggling, we're going to add in a supplement. Because always
Yeah.
when we're trying to do whole foods to get those nutrients, often those whole foods are packed with a bunch of other stuff that's good for you. And so it's always better to try to get your nutrition from food. And we only supplement where there's a gap. There's no great supplement
Yeah.
that is a menopause cure. So
Yes.
nothing's going to resuscitate your ovaries. We have not figured it out yet. Believe me, science is trying, and there's great research going on right now. But right now,
Yeah.
I've seen a million. There was some kind of bacteria you're supposed to eat someone sent me that's going to reverse your menopause. Help me, Jesus. If it sounds too good to be true, it
Oh,
probably is. And so what supplements might do is have the way that your body's responding to this estrogen deprivation, make it respond a little bit better.
yeah. Yeah. I love that. I love that point. And I love the point too of just like being careful of doing your due diligence of research and taking advice from really qualified professionals, because there is a whole market now. Menopause is slapped as a label on everything because they know that it sells, because women are desperate for the information and hungry for the
Yeah.
help.
Yeah.
Yeah,
and they're being
absolutely.
preyed upon. So, and full disclosure, I have a supplement business. I sell fiber, I sell omega-3, I sell some turmeric. So, but again, get it from food if you can. That is the mantra here.
Yeah.
And we only
Well, and I would
supplement where
trust a
there's a
supplement
gap.
I buy from you. I may not trust it from, some other sources
Well,
that I
thank
find
you. I
online.
appreciate your trust.
Yeah.
I appreciate your trust because I do formulate them myself and I test them and, I do all the things. So,
Yeah. I have no doubt you do. If you could go back and tell your 40-year-old self something about
mhm.
going into the phase of life that you've passed through these last, what did you say, 17, so many years, what would you tell her? Like, what would you say to her?
Number one, educate yourself about menopause. Don't take it for granted. The more you know, the more you're prepared, the better this is going to be for you. Number two, nutrition over calories. Really learn about nutrition and don't worry so much about calories. Don't worry about the curves you have. Number three, strong over skinny. There's a critical threshold which we pass that leads us into decline and disability, and that starts in middle age. And so banking that muscle and bone strength in your youth, in your 30s, is going to pay off in the long run so much better. Number four, aging is a privilege, and this can be the best time of your life, but it does take some work. And, I am healthier, I am wealthier, I am happier, I have better relationships, I have better boundaries, but all because I completely changed my focus and shift on health and happiness.
Yeah. And when did that happen for you? Just out of curiosity, like where in your sort of
Ooh,
journey
okay,
did that
so
happen?
if you know my personal history, so I'm one of 8 kids. My mom and dad, my parents had 8 children. My oldest brother died of leukemia when I was 9. So that was childhood leukemia. My next brother died when I was 10 years ago next year. And he was 56. So I will almost be as old as he was when he passed away from liver failure. My next brother died 5 years later in 2020 from esophageal cancer, stage 4 esophageal cancer with multiple mets. And so I have and I have multiple cousins, aunts, uncles, everyone has cancer. So I've got bad juju, like there's something there. And so I may not have the privilege of getting older, and everything I do is based on me trying to live as long as I can. I have 2 daughters and I want to be there. I want to be there for them and watch them. They're becoming incredible adults and I'm so proud of them and I just love them so much. And I just want to be there for them and not have what I went through with my brothers, them have to go through that with me, or at least delay that for as long as I can.
Absolutely. Yeah. Well, I think that's a beautiful note to end on. I mean, truly, thank you so much for your time today. I really do admire you, and I so deeply appreciate just who you're being in the world and what you're doing.
Thank you.
So I also just want to say to people listening that this book is, yes, of course, for the woman transitioning through perimenopause and into postmenopausal years, but it's also for women in their 20s, and it's for husbands and partners and business owners to understand this transition of life and what it entails. So we aren't just ignoring and dismissing a very real challenge that's showing up for women. So, I think everyone should go out and buy it. And I think it's a great gift for
Thank
an
you.
awful lot of people. Yeah. So thank
People
you
are
so
giving
much
them
for
to
being
their
here.
doctors. They're taking them to their gynecologist. I'm like, oh my God. So,
I don't know how you can read the book and not think that, right? I mean, I have an amazing provider. I trust her wholeheartedly, but still it's like reading the book, I'm like, oh, I want to give this to everyone who I am in that level of relationship with in terms of deciding my future with my health. Because there's just so much that is in there that is worth knowing. So yeah, so thank you. Thank you for your time. Thank you for being here. And I hope you have a lovely rest of your day.
Thank you.
Thank you for listening to the Grace and Grit podcast. It is time to mend the fabric of the female health story. And it starts with you taking radical responsibility for your own self-care. You are worth the effort. And with a little grace and grit, anything is possible.